Hello, I'm Natalie Medley, and I'm talking to you from the Indiana Women's Prison. Anna has just discussed America's devaluing of the convict race. She has given examples of the consequences of such a devaluing for communities, families, and individuals incarcerated. Following my paper, Michelle will discuss the civil and social death that we as prisoners experience and the ramifications of criminal justice debt. Today, I question the most fundamental manifestation of the devaluation of the incarcerated, and that is whether our very existence matters at all. If a human being is criminally convicted, does her life, her physical body, or her existence matter? The nation finally sees the shocking expendability of Black people in America because of the Black Lives Matters movement. Imagine how much more expendable our lives are. 2.3 million people are currently in prison in the United States. An additional 5 to 6 million have been in prison. Filter for race, and the numbers are truly shocking. Almost 10% of African American adults are in prison or have been in prison, and a massive 25% of all African American adults have been convicted of a felony. Incarcerated lives should matter, now perhaps more than ever, given our burgeoning numbers, but they don't. Devaluing the lives and the health of prisoners is nothing new. The Indiana Women's Prison, or IWP, is the prison where we are incarcerated. Historians have long considered IWP to be the original prison for women in the United States, although Michelle has done award-winning work proving that they are wrong. More to the point here, Anastazia has done groundbreaking work on the first doctor at our prison, Theophilus Parvin, who served here from 1873 to 1883. While at IWP, he was also president of the American Medical Association and then went on to become the nation's leading OB/GYN of the late 19th century. His annual reports at the prison showcased his brilliance as a physician at the cutting edge of germ theory and immunization. Because of him, none of the women or girls at the prison succumbed to epidemics that killed those around the prison. Lucky them. But unlike historians who have never been incarcerated, especially not sick and incarcerated, Parvin's presence at the prison was an immediate red flag for us. Anna, Michelle, and our fellow incarcerated scholars discovered that what he was really up to at the prison, experimenting on our predecessors, featuring them in his frequent lectures and publications on nymphomania and masturbation, and apparently using them as the unconsenting models for the detailed drawings of female anatomy included his opus magnum, The Art and Science of Obstetrics, published soon after he left the prison. Nor was our prison an anomaly. For example, the first Connecticut prison for women was established in the midst of World War I. Why? Because law enforcement was desperate to find places to hold the 20,000 young women detained in the United States to prevent them from spreading venereal disease among the soldiers. So, Connecticut purchased 2 farms with 5 barns where they stashed the women, nearly all of whom were sent there for being in manifest danger of falling into the ways of vice, or simply, quote unquote, manifest danger. There, they were subjected to experimental treatments. The law that founded the prison made its purpose abundantly clear by declaring that bodies uncollected within 24 hours after death became the property of Yale Medical School. Women, of course, were not the only ones being experimented upon. In his book, Acres of Skin, Alan Hornblum provides harrowing accounts of experiments on male prisoners by American doctors in the 20th century. Indeed, Nazi doctors charged with murders, tortures, and other atrocities committed in the name of medical science used as their defenses that American doctors had for decades done as much and worse to their own prisoners. Well, surely today, in a more civilized time and with more civilized manners, incarcerated persons are not receiving the same dehumanizing, devaluing, and torturous treatment. Regulations were enacted concerning the use of human subjects and medical experiments and drug trials arising in part from the Tuskegee experiments. Prisoners today are not likely to be forced into formal experimental protocols, yet their lives are devalued in many other ways. For example, a woman in prison who discovers a lump in her breast cannot obtain a mammogram or biopsy unless her prison's healthcare provider deems it as worthy of a follow-up. If she suffers from kidney disease, she cannot be put on a transplant list, even if she hasn't a donor identified. If she has diabetes, she has little or no access to up-to-date information on latest developments and treatments. If she is pregnant, she may be shackled while in labor and even sterilized, which happened as recently as 3 years ago in California. If she has Hep C, she can be denied treatment. If she has HIV/AIDS, her needed medication can be unreasonably delayed, making the medication less effective. She is not given unfettered access to her medical records, and her family or designee is denied information concerning her health. And even if she dies while in prison, she will not be seen as having been fully human, as exemplified by the recent headline in Indiana that read, "Offender dies after outbreak." International human rights organizations have taken stands on what constitutes the humane treatment of prisoners. How does a nation like ours add up? The fact remains that the U.S. is committed to mass incarceration, and arguing whether it should be is not going to change that reality anytime soon. The United States has the highest prison population of any civilized nation on our planet, with 1/3 of all the world's female prisoners. The reality of what constitutes humane treatment of prisoners has to be addressed. Prisoners, ex-prisoners, and felons are the most vulnerable of populations. Substandard medical care is a public health crisis in light of the 600,000 people being released from prison every year and going home to their communities. The decisions of our courts reflect the values of our society. It was not until the 1980s that the courts mandated basic health care for the incarcerated in the U.S. Today, the health care providers, most oftentimes outsourced for-profit companies, are fully aware that the constitutionality of prisoner health care requires minimum adequate care. Yet prisoners, as a vulnerable population, more often than not, are indigent without access to legal assistance. And the standard of care, as deemed acceptable by the courts, requires more than negligence on behalf of the healthcare provider, but rather a higher burden of proof with a much lower standard of deliberate indifference. The contractual agreements of our states reflect the values of our communities. Over 20 states in the U.S. outsource some or all of their medical care to for-profit companies. The fact that states continue to contract with these companies despite the lawsuits brought on behalf of prisoners, and most often the estate of a prisoner who has died while incarcerated, reveals how little incarcerated lives matter to the bottom line of our communities. This brings me to my first proposition. For-profit healthcare is never an appropriate model for vulnerable populations that have no alternative access to healthcare. Due to the steady depletion of community-based addiction and mental health services, prisons and jails have become mental institutions by default. The extremely punitive measures of these institutions only exacerbate the problems for these individuals, most of whom will return to the community. What happens in departments of correction impacts everyone, from the release of seriously mentally ill individuals from prisons directly to our communities, or the tremendous increase in costs for treatment, care, or awards and lawsuits that might have been prevented. Most important, the needless increase in human suffering when force replaces medical care is something that should no longer be tolerated by our nation. Financial incentives are driving deplorable practices in medicine. All vulnerable populations are at risk for violations of their humanity due to the for-profit healthcare industry. The example of feeding tubes being used from Guantanamo Bay to nursing homes reveals that the cost of careful hand feeding is not the most effective way to feed our elderly and dying. The staffing of nurses to perform the task of hand feeding requires more money than inserting a simple tube. The New York Times reported that nursing home residents in for-profit nursing homes are 6 times more likely to be subjected to force feeding rather than hand feeding than the residents of non-for-profit homes. The title of the article Force feeding, cruel at Guantanamo, but okay for our parents, proves that vulnerable populations are exploited when the bottom line is at play and no independent oversight is conducted to guarantee humane treatment. It appears that the perceived bottom line for the for-profit prison healthcare corporations is that it is more cost-effective to deny preventative care, delay diagnosis and treatment, and ultimately allow human beings to die in institutions across our country than to guarantee the Hippocratic oath of a licensed medical professional. The moral code of the medical profession is undercut by the need to increase profits for shareholders in the for-profit industry. Humanity is lost on the tide of cutting costs. Privatization is not the solution to the serious deficiencies in medical care as seen in the criminal justice system or as in the former example. In Arizona, the American Friends Service Committee reported that, quote, privatization complicates the problem further by inserting an entire corporate culture and structure inside the existing state agency bureaucracy, providing both parties an opportunity to dodge responsibility and pass the buck, unquote. This brings me to my second proposition. If incarcerated lives matter, we need an incarcerated patient's Bill of Rights. The world-class Johns Hopkins University Hospital and Medical School has its own patient's Bill of Rights. Of the 15 rights outlined, only one can be said to apply without reservation or modification to prisoners, and that right has been guaranteed by our courts. Because of prisoners as a class of people having historically been abused, used for experimentation, denied medical care, and dehumanized, the courts determined that inmates have the right not to be coerced or forced to participate in medical research studies. However, none of the other 14 rights can be said to apply fully to an incarcerated person. We have no right to respectful, compassionate care. Though we may receive it, it is not a prerequisite to our health care. In fact, it may also be quite the opposite. We have no right to a safe environment free of all forms of abuse or neglect. Although it is naively assumed that the vulnerability of a patient would not be exploited, it is not guaranteed. An inmate has no right to request someone else to be present with her throughout a medical consult or procedure. The inmate certainly has no right to receive care in an environment that maintains dignity and adds to a positive self-image. Prisoners are often told of their burdensome state when requesting medical care, even basic over-the-counter medications. Inmates have no rights or even access to the information of being told the names of our healthcare providers. It is considered a security risk to have a family member or a person of our choice notified upon our admission to the hospital. Our family or designee is denied communication with the healthcare provider upon the healthcare provider's discretion during any medical procedure. Inmate patients definitely do not have the right to have someone remain with us for emotional support. We can be left in the dark about our diagnosis, prognosis, the benefits and risks of treatment, and expected and unexpected outcomes. We would love to have the right to have our pain assessed and to be involved in decisions about treating our pain, yet we are treated as addicts, and our pain is discounted by the fact we are not able to support ourselves or provide medical coverage by the lack of employment. As inmate patients taken off of prison grounds for medical treatment, we are always restrained and escorted by armed officers. Even women in labor are shackled. Restraints are used regardless of the medical necessity. Although HIPAA laws do apply to prisoners, we have no guarantee of privacy or confidentiality. The designation of family or another person to participate in decisions about our care, treatment, and services is not an option for the prisoner. We don't have a full right to communication we can understand, prescription information, potential side effects or drug interactions, or to make advanced directives concerning potential future medical care, follow-up care, or to be involved in our own discharge plans. So what might a prisoner's health care Bill of Rights look like? In addition to the standard Patient's Bill of Rights as exemplified by the one at Johns Hopkins, an incarcerated health care Bill of Rights would A. Enshrine the doctor-patient relationship as central to our care. That may sound obvious, but for people in prison it is not. B, provide full access to information about our own medical records for ourselves and those we designate. C, give us the right to obtain a second opinion, preferably from a physician of our choosing. D, the right to standard preventative care. E, the right to a continuity of care from pre-existing healthcare providers who are released back to the community. F, referral for diagnostic testing. G, the right to the same standard as given the surrounding community. These rights are worthless if they are not enforceable. This brings me to my third and final proposition. Prisoners and other institutionalized populations that have limited control over their health care should by right and default have recourse to an independent ombudsman who at minimum has no financial interest in our care and no ties to the DOC and agencies providing health care. Incarcerated people's lives should matter because human beings are human beings regardless of their physical circumstances. Because the vast majority of prisoners will not be prisoners forever, but will indeed be citizens returning to your communities. Because the law binds the state to legal responsibility over our care and well-being. And because we were sentenced to incarceration, not torture and not death. To those of you who are unlikely to ever be incarcerated or have someone you love incarcerated, though you are a rapidly shrinking demographic, you are powerful nonetheless. I want to leave you with a final thought. An incarcerated man was sentenced to 20 years in prison on a drug charge. He had symptoms that revealed his previously noted medical condition of a blood clotting disorder and other health issues. Within 2 years of his incarceration, his condition deteriorated. Upon the loss of 20 pounds in a month and critical levels on his lab work, he was left for days with no treatment. His family repeatedly tried to contact prison officials to determine his location and his well-being, yet were met with no details, erroneous information about his location, and the assurance that he was fine. Within 1 month, their son was dead. Unknown to his family, he had been sent to the hospital where he was shackled to a bed while in acute respiratory failure, renal failure, pneumonia, and sepsis, all while placed on a ventilator. Despite medical specialists insisting that he be sent to a long-term care facility, and despite being unable to walk and unaware of where he was discharged back to prison. On the ambulance ride post-hospital release, he died. Sadly, the man's family had a hearing scheduled for their son's release from prison due to his medical issues mere days after his death. He was 22 years old.